I'm Nikita, and I'll be hosting today's session. For those of you who've been with us before, welcome back to ILS. And for those of you who are new to our community, I'll take just a second to introduce ourselves very, very briefly. ILSS, or India Leaders for Social Sector, is a learning and leadership development organization for the social sector. And we started about 2 years back with our flagship leadership program for senior executives who wanted to make a meaningful transition into their own journey of social impact. And so we run this program as a 9-day residential course, which attracts the best talent from across industries. And we take them through this journey, through sessions and faculty who are the top experts in their own fields in the development sector to understand the work that's happening and the role that they can play in the development sector. ILSS Online, as you all know, is our latest offering wherein we've had industry leaders from across the development sector, policy makers, think tanks, academics, and so on, come and talk about their work in the COVID-19 context and beyond. And we soon hope to launch professional development programs for people who are already in the sector. And we'd love for you to look out for our course for fundraising professionals, which will be coming up very, very soon. If you enjoyed today's session, do look up our flagship program, the next edition of which will be happening in August this year. The applications are already open and are being reviewed on a rolling basis. So for any further information you require, do reach out and we'll be happy to help you with it. Coming back to today's session, we are very, very pleased to have with us Dr. Ramanan Laxminarayan, who's the founder and director of the Center for Disease Dynamics, Economics and Policy in Washington, D.C., and also a senior research scholar at Princeton University. Ramanan is an affiliate professor at the University of Washington and also a visiting professor at universities in Scotland and South Africa. He chairs the board of GARDP, a global product development partnership created by the World Health Organization that aims to develop and deliver new treatments for bacterial infections. He's also founder and board chair at HealthCubed, which works to improve access to healthcare and diagnostics worldwide. Since 1995, he's worked to improve the understanding of antibiotic resistance as a problem of managing a shared global resource, and has played a central role in bringing the issue of drug resistance to the attention of leaders and policymakers worldwide to the United Nations General Assembly in September 16. Ramanan was also served as the US President's Council of Advisors on Science and Technology's antimicrobial resistance working group during the Obama administration. And in 2014, he created the Immunization Technical Support Unit that supports the immunization program of the Ministry of Health and Family Welfare of the Government of India. He's been named a distinguished alumnus by the Birla Institute of Technology and Science in Pilani in 2019, and also by the University of Washington Department of Economics in 2020. His work has been covered in major media outlets, including the Associated Press, BBC, CNN, Economist, LA Times, and many more. So, an absolute pleasure having you with us, Ramanan, and I'll hand it over to you.
Thank you so much. Thank you so much, Nikita. So I'm going to, so can I share my screen?
Yes, absolutely.
Okay. So I think you may have to give me some, it says it's waiting. Okay, hold on. All right. You can see my screen here?
Yes, we can. We can.
Okay, okay. All right. Thank you so much. This is, it's lovely to be able to speak with all of you. Unfortunately, I can't see you, but at this point, you can't see me either. This is just a very, short introductory slide deck on just COVID, and it's really meant to sort of set the context for the situation that we're in right now. In fact, a lot of these slides come from a class that I've taught for almost 14 years at Princeton. So in that sense, it's not even that, it's not necessarily that new in that sense, because this is all things that we've known for a long time. But I think once we've gone through this, then it sets a context for, the questions that you would have, which are really related to, economics, the social sector, what it means for people, whether the lockdown is killing more people than the virus actually will, etc. Why there's such a sharp response. And I can address those questions, which are not necessarily in the deck, but we can go through this. So COVID, of course, it's a coronavirus, causes common cold. Also, now everyone knows about COVID. So I think this is all, pretty unnecessary. But one thing to remember is that these kinds of global transmissions have happened for years and years. In fact, started, the earliest, times the world ever agreed on anything, even before there were Geneva Conventions or labor laws, was when countries agreed that they would share information when cholera was spreading, because cholera would spread routinely from Southeast Asia, starts typically in the Bay of Bengal, and then goes into Central Asia, into Europe, and into the US, where it would kill tens of thousands of people in Philadelphia and New York. And then the world agreed in 1850 itself that, look, if you have cholera, you've got to tell me. And this is like these were the global sanitary conventions. So the idea that the world cooperates on infectious diseases is about the oldest forms of global cooperation on anything. We didn't agree on torture, we didn't agree on labor rights, but we'd agreed on disease back in 1850, when most of the world was not a democracy, most of it was a monarchy or colonies. Now, this is actually chloroquine resistance, which started in the 1950s, spread across India, and then into Africa in the 70s and the 80s. So usually when you see disease spread like this, or, this is a strep pneumonia 23F clone, which is now the most predominant clone of pneumococcal pneumonia around the world. And pneumococcal pneumonia still kills about 200,000 children in India every year, 200,000. These have moved at a much smaller slower time frame. So they typically move in the space of years. So the New Delhi metallobeta-lactamase, which is an enzyme that confers resistance in antibiotics, to antibiotics. This started probably in India in the late 2000s, 2008, 2009. And within about 5 years, it has become global. So all of these start in one place and go everywhere else, but we usually have time. We usually have 4-5 years. It's very rare that you have a disease that was first detected in someone in China in 2000 on November 17th, and then by January it's become a huge epidemic there, and then by February and March it's killing tens of thousands of people in Europe and the US. That's pretty fast. Now, if you look over time, every week of the year, there is some infectious disease that is trying to jump from animals to humans. What has happened in this coronavirus is not at all unusual. It happens all the time. It's only rarely that these viruses are then able to jump from one human to the other. Jumping from an animal to a human can be accomplished, and then that's an evolutionary dead end. Jumping from a human to a human is a very special skill set. So, and if you can see over time, 50s, 60s, 70s, all the way through to now, and this paper was published in 2008, so not the entire decade, that the number of infectious disease events has been increasing over time, mostly because we encroach on nature, we encroach on animals by eating them, and we have wet markets and so forth. So most of these are what are called zoonotic diseases. They jump from animals to humans. And many of them are vector-borne, but most are actually non-vector-borne. Now, COVID is an example of a non-vector-borne disease, which means there's not a mosquito or something in between. It's just basically jumping directly from one person to the other. And so these disease events, obviously, they're not clustered in Europe and US. It just happens to be that these are places where, they are reported most often, but they've been reported in India as well. There are new emerging diseases that have emerged only in India. There are ones which have emerged only in Southeast Asia. These happen every day. In fact, in the world in which I live, on emerging infectious diseases, every morning you get a newsletter, which is of people reporting from around the world things that were unusual that have been picked up. That will be doctors or ID clinicians. And you look at it and say, okay, but I don't know if it's actually going to turn into something much bigger. What has happened with COVID is unusual in the space of people who are paying attention to this. And the risk of zoonotic disease is concentrated in South and Southeast Asia because there is close proximity between humans and animals. And I know the social sector is very involved in what is happening with COVID and lockdown, but I think you have to take a longer view of things in terms of, what our dietary patterns are, what are our farmers growing, the fact that India is going to consume, 6 times the amount of poultry in 2030 compared to 2000. What's the impact of us raising, of China consuming 6 times the amount of pork as the US? These have tremendous consequences for our risk of these diseases because pigs really, I know, people commonly say men are pigs, but actually human beings are like pigs. We're very similar to pigs in terms of how viruses are able to be, recombine within us compared to, within pigs. So a lot of the diseases that we get are very, close from pigs. And in fact, in wet markets, and a true wet market is like this. This is heads of goats, there's other entrails, there's live poultry underneath, but usually you'll see snakes, you'll see lots of other things in close proximity to each other. And these are ideal places for viruses to be able to jump from a pangolin or a bat or anything else into a goat or a poultry or a pig, and then make its way into us. It's we make it very easy for them when we do this. And certainly the fact that we live in close proximity to animals does not help at all, because it's very easy to transmit these. Now, it doesn't happen that, again, like I said, human to human transmission is a challenge, but it has been almost, it's been many years since we've had a truly novel virus that kills a lot of people like COVID does. And that's why this is an issue. And we've not had this in a few years. H1N1 was very transmissible, but didn't kill a lot of people, fortunately. Now, this is how it actually happens. So you have the disease in the animals. It could be primates, or it can be rodents, it can be bats. It spills over into the domestic animals and then spills into the humans, and it amplifies in humans. And this is the point at which we start picking it. So we are like in this phase in the epidemic over here, but this epidemic started a long time ago in the animals itself. And if we are trying to control it over here, it's too late. We need to control it much earlier in forecasting and early detection, all of which we spend almost no resources on. And we look at it over here and say, oh my God, something happened. It did not happen here. It happened a long time ago. We just didn't pay attention to it. Now, I'll give you an example of SARS in China. And the reason I want you to understand SARS in China is because as a historical context, if we had not had SARS in China in 2002, we would all be in much worse shape right now. Because SARS in China in 2002 was about an example of how badly you can handle a situation. November 2002. So notice the parallels here with COVID. November 2019, you had reports of COVID. November 2002, there was atypical pneumonia cases that went from Guangdong CDC to Beijing. The capital said to Guangdong CDC, we don't want any bad publicity from this. Please shut up. Don't tell anyone about this. Now, they started their research by February, and it'll remember, November, January, February, December, January, February. 3 months later, they determined that SARS was caused by coronavirus. They said, we are seeing something unusual, which we are calling SARS, but they didn't reveal that it was caused by a coronavirus. They didn't release a sequence, nothing. Very different from now, where by January first week itself, they had actually released the sequences of the coronavirus. So all this happened because China behaved so badly at that time that they improved their behavior, but not sufficiently for the world to protect itself. It was only in April that the World Health Organization was able to determine that SARS was caused by a coronavirus. And by which time, sometime in February, one doctor from Guangdong who was sick checked himself into the 10th floor of this Metropole Hotel in Hong Kong. Okay? And this one doctor effectively transmitted the disease to people from Canada, Ireland, US, Singapore, Vietnam, and Hong Kong just through the air ducts in that floor. Okay, and this is true even for COVID. I think when it's actually done and dusted, we will find that a few people were responsible for much of the transmission. They're called super spreaders. So each super spreader will transmit up to 100 to 200 times the amount that the rest of us do. We don't know why there are host factors, but there are some people who just happen to have much more viral shedding. They shed more viruses than other people do. But anyway, be that as it may, this Guangdong doctor went and transmitted. In fact, from Vietnam, the doctor who treated the very first case in Vietnam happened to be a good friend of mine who died. He was the first person to die in Vietnam. And this just all happened so very quickly and nothing could be done about it. Fortunately, SARS died out for reasons that we don't know about. And we have no idea why it just disappeared and never came back. It's unusual to happen, but not completely unusual because it can happen, but only when you have, remember, SARS at its peak had 50,000 cases and about 10,000 deaths. So much less than COVID, which is, at last count about I think about 240,000 deaths or whatever. So we are past this point for COVID. And we've known all this for a long time. In fact, I've written about this for years. Other people have also written about this. This article was in 2002, and the article title was, preparing for pandemic. It's $1 trillion externality. And, what I said in this article was basically this, which is, look, you look at what has happened before, and it's clear that a pandemic doesn't have to kill millions of people or even hundreds of thousands of people to shut down international commerce. Even a few thousand deaths over a short period is enough to inflict significant damage on the global economy. That includes everyone from day workers to farmers to large corporations. Everyone is affected. But all of this should not come as news to anyone, because we've known about this and we've been writing about it. We've had seminars about it. We've had lots of things going on about it, just that no one really pays attention until there's an actual pandemic. But so this was never really new. Now, as far as India goes, you can think of COVID as sort of a slow-moving asteroid hitting the country. To some extent, you can dance your way around, but some point it does actually hit. And India, I think, has done the best possible, in order to minimize the impact as much as possible. And I don't think, there are certainly things that could have been done much better with migrants and so forth. From a disease managed standpoint, I think they have been decisive in ways that I've even been surprised that, oh my God, they're actually taking the health threat seriously. And I think that's actually to the country's credit. Of course, there are things that could have happened much better for sure. So SARS, coronavirus was identified as a causative agent on 7th January. They told everyone about it on 7th January. Now keep in mind, they only told the world, in February or March when it was the earlier SARS. And the health ministry had already issued advisories. They started screening people. They stopped flights to China. They literally would quarantine people getting off of flights. They evacuated these students from Wuhan. We could have had our first cases by the end of January itself. If you ask, why do we have only 1,000 plus deaths and other countries have 50,000 plus deaths? My answer would be that it was this. It is because we bought ourselves 1 month of time with this, that we didn't allow any cases to really come in a serious way at that point in time. And, after that, WHO acts, et cetera, and, India evacuates its citizens, et cetera. So point is that this was a very critical month for those first 2 weeks when we could have had the disease and we didn't. And we ended up having our first death in India only on March 2nd. And a simple math is that if you see a death from COVID, it means that 2 weeks before there had been 100 cases, because 100 cases 2 weeks ago result in 1 death today. That's a rough math of how this stuff happens. So the fact that we didn't have any deaths until March 13th means that we really didn't have COVID until about March 1st. So March 1st is when our thing starts. And what, this was published on March 27th. I think I wrote it around the 20th. Was, I basically said in mid-March that we're going to have, 300 to 500 million cases, infections. Now, and I also said that 300 to 500 million infections, most of them will be mild or asymptomatic, but still we will have a significant load of cases and mortality. And I still stand behind that, because this is not a question of some magical projection. Anyone who studies viruses, this is just what happens everywhere unless you're able to significantly flatten a curve. Obviously, a lot of criticism around this, but people don't study infectious disease for a living. So I can understand that, from someone else's space, it seems a little odd. But all that we were looking at was about 3 to 4 weeks to be able to create the infrastructure in order to prepare for the outbreak when it actually happened. And that's the space that we've actually had. We've bought ourselves 3 to 4 weeks. So we've effectively postponed the peak by about, I would say, 4 weeks at this point in time. So India, of course, was much more proactive. India had, a lockdown very early compared to places like Italy, which only locked down after the cases were starting to increase quite a bit. Or Spain or Iran. And keep in mind, India is a much bigger country. So as a proportion of its population, its lockdown was even earlier than these countries. So if you account for population, all these curves will be much higher than it is, right? Because, Italy is only 1/20th the size of India. So you're talking about curves that are all up here, and India is locking down over here once you adjust for population. Now, we did a bunch of modeling. You have these ages, these are complex models, and some at some level, they're not even needed for something as gross as COVID. But the fact is that they give you finer precision, but, it all depends on who's coming into contact with whom, and also amounts of testing. So India has always been very low testing, and its positivity rate has sort of been somewhere in the lower end of things, because we've had a very selective pattern for how we test. Countries that test a lot more also have had higher positivity rates in general. So most of the numbers you'll see are to the northeast of India, not to the southeast. So southeast would mean that they are actually testing more but finding lower positivity. That's not the case. Generally, countries that test more actually find more cases, and that's true within India as well. Now, you can see that most of the cases in India are in the West. Why? Because they're either in Delhi, Maharashtra, Kerala, and to some extent Tamil Nadu and Karnataka, but also Punjab now increasingly, is because these were where the travelers came in from outside of the country. And COVID is an example of a totally inequitable disease, which is brought in by the rich, but the lockdown has effectively shifted the disease to the poor. So because the rich are able to socially distance and the poor are not able to socially distance. So you bring in a disease, but then effectively it's going to be a disease for which the poor are going to take a bigger impact in a proportionate sense because of just the way in which we're able to control the disease. Because they don't have the essential tool of physical distancing to control the disease. So I'll skip through this, which is just the math of how all of this happens, and just go straight to what it's a couple of important questions. Some people have asked, well, is temperature a big issue? We have some data from China showing that maybe temperature, brings down the spread of the disease, but not by enough. Even if there was a case of temperature slowing down the virus, it is not by enough to avoid the total amount of infections that we would have, or from humidity. And in fact, we're not finding this kind of evidence from India at all, where Tamil Nadu and Kerala, they have no problem with virus transmission. And most of what we know comes from, this Yokohama Diamond Princess cruise ship, which was a very nice experiment, where there were a lot of passengers on board that ship, 3,700. And this is where we learned the lockdown strategy, right? So Feb 3rd, they had 10 initial cases. Feb 4th, everyone was quarantined. Every single person on Feb 4th was quarantined and sent to their cabins. Feb 20th, they only had about 619 cases confirmed. But think about it. Here is a disease where on the Feb 3rd, you've put everyone in their cabins and you've locked them down. But still 17 days later, you have 60 times the number of cases, right? Doesn't this look a lot like India, where on the day we went into lockdown, we had 400 cases reported. And then we are supposedly coming out of lockdown with almost 40,000 cases. That's because this is a highly transmissible virus, highly transmissible. And isolation quarantine may have prevented about 2,300 cases, just like in India, we probably averted hundreds of thousands of cases because of the lockdown. So the lockdown did have a huge impact, but you'll only see that through modeling. You're not going to see that by observation, just because you only get to observe one state of the world. And a total of 634 people were tested positive, and many of them were asymptomatic. But in our model, we assume that more than half, probably closer to about 70%, are asymptomatic. And most of the remainder are going to be mild, and only about, overall, our rough number is that 3% of all infections will be severe, and 1%, end up dying. This is very consistent with the rest of the world. 1% of all infections. Remember, you don't get to observe infections when you look at Ministry of Health reports. You're only seeing number of reported cases. And our estimates are that the number of infections is about roughly 10 times the number of reported cases. 10 times. So if you see today that, I don't know, something like 40,000 infections, our estimate is that there are about 400,000 actual infections out there. Okay? And this is how we've done a lot of this. Now, the other sector that maybe all of you should be interested in are children. Our children were less likely to be infected and hospitalized in Wuhan, in Europe. But you have to remember, first of all, they have far fewer children. That's number one. Number two, their children are much better fed and are in much better health than our kids are. Their lung capacities are better, they're better nourished. We have a lot of kids who are not in such good shape, low birth weight, etc. So, and we already have started to see, more than a disproportionate number of deaths in infants, in the first 6 months of life. And that's a real concern for us because even though, young people are less likely to be infected than older people, infants amongst that population are the highest risk category. So, once you've crossed the age of 5, you're in much lower risk. But if you're an infant, you have almost 2.5 times the risk of someone who's age 6 to 10. These are model assumptions, but I'll just jump straight to it. I can share these slides as well. But this is the fundamental math that you have to remember. Okay, at a doubling time of 3 days, which is what was happening in Spain or Italy, and this is why I made the initial predictions that we did. 100 infections can grow to 500 million. Actually, to be accurate, it's about 420 million in just 66 days. Because it takes about 22 doublings to get from 100 infections to 420 million infections. Just 22 doublings. If you look at our death rate, we've already completed 12 of those 22 doublings. So from a virus perspective, getting from 0 deaths to 1,000 deaths is the same as getting from 1,000 deaths to 2 million deaths. Now, just absorb that, because this is not the kind of math you see in real life, but that's how exponents work. 0 deaths to 1,000 deaths is the same number of doublings as getting from 1,000 deaths to 2 million deaths. Because you're going from 1, 2, 4, 8, 16, 32, 64, blah, 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 all the way to 1,000. But from 1,000, you're going to 2,000, 4,000, 8,000, 16,000, etc., all the way to 2 million. This is why we are deeply concerned about this virus. This is the reason for all the strict measures of lockdown, etc. That if you just, if you know how the virus spreads typically in exponents, that it gets to high numbers extremely fast. And 66 days is what? 2 months. So if I tell you that the math would suggest that in 2 months you get from nothing to 420 million infections, and that will happen only in India, because India is the country which has a population that you can't really fully lock down, that we have, a population that cannot physically distance, that you can't control the way the Chinese can control their population. That's why, there were reasons to be pessimistic about India back in mid-March itself. But I want to explain why it is. And this math, I don't need a fancy model to explain it. You can do this in your Excel file and you can see the same thing that I can, right? You can just do do the doubling on your Excel file and see how fast it happens. And the slowing down the doubling time through intermediate measures has a greater impact than sharp lockdown. So sharp lockdown was initially good, but from now on, our fate is going to be determined by how much we're able to have people cooperate to slow down the virus. The more we slow down the virus, the less sharp the peak will be. So anyway, we modeled a bunch of scenarios, but this is what we had. This is the first 21-day lockdown, not beyond that. So I'm not showing anything beyond that. But clearly the lockdown, with the lockdown, we're in the red curve. Without the lockdown, we're in the green curve. So the lockdown does slow down quite a bit, and it's a delayed impact. So keep in mind again, the people who are dying today were part of the bunch who were infected 2 weeks ago or 12 days ago. The people who are infected today, and 12 days ago, the numbers of infections were something like 15,000. So those 15,000 infections or maybe I think 12,000 infections have led to the roughly 1,200 deaths today. So today's infections are, at about 40,000. So you can project forward to see what the deaths would be 2 weeks from now. Okay, so I don't want to get too much into this stuff, but basically to say that the whole idea was to buy time, to prepare hospitals for surge cases. That's all it was. It was not meant to be some long-term way in which we fought the disease. The disease is not gone yet. The disease continues to grow, and it's growing at a slower exponential pace, but still growing pretty fast. And reducing cases in following weeks will work if we socially distance, and that's how we can really do it. There are lots of policy options. We can do this and so forth. I don't want to get into it, but fundamentally, look, this is the peak we would have had, and depending on the lockdown, we would have moved it to the right. But if we change our behavior, we can actually lower the peak itself, which is what we want. But one thing which is inevitable is that the area under this curve, which is the total number of infections, is not very different from the area under this curve. So it's a question of whether you take your 420 million or 500 million infections over a longer period of time, in which case the health system can adjust to it, or you have it over a shorter period of time. And remember that our mortality from this disease is entirely a function of how much the health system is overrun. If you have 10 people waiting for one hospital bed, you'll have a lot of deaths. If you have only 2 people waiting for a hospital bed, you'll have far fewer deaths. And we are working for, in fact, that's the call I was on just now for 2 hours, which is on what our mitigation strategy is going to be, so that we can have these trains that are rushing to places that can actually, ways in which there's enough bed capacity. And the good news is that although it is not visible to everyone on the outside, the government has done a lot in terms of preparation for this surge, a lot. They've not just been sitting around. The surge capacity right now is probably about 4 lakh beds, which is what they will bring. This is for a country which has only 1 lakh ICU beds. To add a 4 lakh surge capacity is not trivial. And sure, we can always say, yes, they should do more, etc., etc. But at least they did 4 lakhs. And given our limited expectations of government, I think this is all, something which I'm impressed. We do important. We have to ban mass gatherings. We have to encourage distancing. We have to encourage face covering, hand washing, all the stuff we said from day one, teleworking where possible, everything. We also recognize that there are costs. Now, I'm putting it in dollar figures just because, an economist thinks in terms of money. You can say 30,000 crores or $4.5 billion. But the human cost is obviously enormous, and that's indisputable. But also the psychological damage of having a huge number of deaths, like 2 million deaths within a 6-week period, is also quite damaging. So we've got to figure out what it is that we want to make a choice on. And we've bought enough time. So that's why I've basically been saying the lockdown is not worth it anymore. That COVID is also going to be with us for a long time. It's going to be with us for a long time. But our estimate is that at the rate at which we're going, India will be the first country to emerge from COVID, because the reason is because our lockdowns are not super effective. So our infection rate has continued. Therefore, we will reach herd immunity much before any other country. We have the ability to actually shut down transmission like they've done in many countries, like New Zealand. New Zealand will take forever to get herd immunity. Maybe they'll wait for the vaccine. That's not an option for us. So we will actually get to that herd immunity. And once we get to 65% infected, then the remainder are safe, because the virus will find it difficult to jump from one person to the other. So I think that's about all that I wanted to say, and I could stop here and take questions. Thank you.
Thanks, Ramanan.
Sure.
So just coming to the questions, I think one question that we're getting is to maybe see India's status vis-a-vis some of the other countries. So for instance, one of the things that you said was that the actual cases in India at least are likely to be 10 times more than what's being reported. Does that stand as the same in other places as well? Or is there something about our testing rates and so on that impacts that figure differently?
No, it's actually quite in line with other countries. So this 10x, let me separate these two words, because people think of cases as somebody going to a hospital or feeling sick. To an epidemiologist, we don't really think in terms of cases. We think of infecteds or infections. So for every 100 infections, only 20 will be symptomatic or worthy of our attention. The other 80 are important from a perspective of disease transmission, but otherwise not. So for every 100, 20 are the ones I really care about. Of the 20, only 3 are going to go into a hospital, 1 is going to die. Well, hopefully not, but we'll do our best. But these are just the statistics of it. So we are picking up roughly 10 out of every 100, okay, consistently, because our testing capacity has also grown with our infection rate. We were testing 2,000 people a day at the time of the lockdown. Today, we're testing something like 80,000 people per day. And the testing capacity will hopefully grow to something like 500,000 people a day in the next 3 weeks. So I would say that, yes, we could have done far more testing because that slows down the epidemic. But we are not, as a proportion of infections, we are not that far behind other countries.
Right. Also, now that today is good timing. We know that there's going to be a lot of change in the staggered lifting of the lockdown, if we don't want to look at it as an extension of it. Now, more movement has started, and especially with the trades for migrant workers, and some of the non-essential movement will start back on. Do you think that that's going to again be detrimental in the coming few weeks?
See, let's actually again see. We've slowed down the epidemic with the lockdown, but we've not slowed it down such a huge amount. Okay, because transmission continues to happen. It happens in Dharavi, it happens in any sort of community, even in housing colonies. If you happen to live in a house where your next neighbor is across a wall, then you're in better shape than if they're not over the wall. So certainly transmission will go up, but I don't think it's going to go up to any extent beyond what we were before lockdown. And we are going to see a peak in any case. So that's what we all have to be prepared for. So at this point, there's always a trade-off. If the trade-off is, let us trade off for things that are economically valuable and allow those activities. So if someone were to say, I can either shut down all the movie halls across India, or I can stop the Bombay suburban trains, I would say shut down the movie halls across India. Because those Bombay suburban trains keep a whole bunch of people working. I think the trade-off is, let us pick the most economically valuable activities which sustain everybody, especially the poor, even if they increase disease transmission, but shut down stuff that increases disease transmission that is not economically valuable, which may be good for us, fun, etc., but I think we can live without masked weddings, like weddings of 1,000 people till the end of the year. I don't think anyone is going to die of hunger if that did not happen. So that is the kind of choice that your leadership will have to make, to say, let's pick the things that are sensible. We're going to have transmission. We're going to have lots of people in one place. Let's pick the things where we say, I'll pick these few things. These other things I'll do without.
Right. Also, any comments on contact tracing? With Arogya Setu, of course, a lot of people have also had concerns around surveillance, what happens further, and so on. Yeah. But what are your views on contact tracing?
See, I think, so first of all, privacy is a concern, and I think that's a legitimate concern. In fact, if I were in the position of what the government could do, they should just say that on such and such date, maybe on January 1st, 2021, government will delete all data from Arogya Setu and everyone will delete their app. We will have an app. With this purely temporary measure, that it should be public, the data is not going to be stored. And I think that will reassure a lot of people, which is why they're not probably downloading the app. The days of contact tracing were over a long time ago. Today we're into community. Contact tracing means that you say, I am infected, and then who are the other people I'm going to infect? What does it matter? Today you're only picking up 1 in every 10 cases. The other 9 are anyway transmitting. How many ever secondary cases you prevent from me, the other 9 are anyway, transmitting those cases. So that's why contact tracing at this stage in the epidemic is over. Students came on to a stage of saved us for 4 weeks. So it had a time and a place, but that time is over. Hello? Hello? Yeah. I don't know. Could you hear that, or did that not happen?
Yes, we could hear it in bits because your voice was not very clear. But yeah, towards the end, we were very clear of what you said. I'll just take other questions. There are questions about vaccination, Dr. Ramanan. What are your views on, is that the ultimate solution? And when do you think it would come? Because the news reports have been saying 12 to 18 months.
So we have to remember that even in the best of times, vaccine take at least 6 years, all the way up to 20 years. It's a very long process. And it's important to get the vaccine right and not just jump into the first vaccine, because this is a vaccine you're going to give to every single person. You want to make sure that the vaccine is completely safe. Let us say, for argument's sake, that we rush a vaccine in, But for whatever reason, 1% of people getting the vaccine have some really terrible side effect, which does happen with vaccines. So whatever you gain from COVID, you've lost on the vaccine, and you've destroyed confidence in the vaccine, right? And not just this vaccine, you've destroyed confidence in all vaccines. So I think we've got to be very careful, understand that vaccine development, toxicity, all this takes a long time. And I would say that a year is ambitious. A year and a half is probably more like it, because even after you develop a vaccine, and there are literally 120 vaccine candidates out there, so every day there's something coming on, it is very difficult to take those vaccines both to the end of licensure, which is basically that is approved for use, and then after that is an equally long time. It takes another 6 to 12 months to scale up the vaccine in order to make the hundreds of millions or possibly billions of doses that are required. So for me personally, I don't consider the vaccine as anything that's relevant to me for 2020 at all. 2020, we're on our own. 2021, we'll see.
Right.
Okay. We have a question here about the testing methods, Ramanan. If you can comment on the effectiveness of rapid tests vis-a-vis PCR tests.
Okay, so the best way to explain this is that there are basically two testing methods broadly. One looks for virus in your body, the other one looks for antibodies which your body develops in response to the virus, or indeed in response to any bacteria or anything else that may invade your body. The test for the virus works between 1 and 10 days after you have shown up with symptoms or that you had the infection. So the RT-PCR has its time and place, which is in that first 10 days. It is not 100% sensitive, it's only about 70% sensitive. By sensitive, I mean, if 100 people have COVID, the RT-PCR will only pick up 70 people. Okay, so it's not a perfect test. So that only works in the initial stage. After about day 7, day 8 of infection, the antibodies start appearing. There are many kinds of antibodies. Some help protect in the short term, some help protect in the long term. The antibody is basically something that's always in your body that's able to identify the structure of the virus so that the next time the virus shows up, the body can get rid of it. Now, all of us develop antibodies because if we did not have antibodies, the virus will stay in our system forever. But we know that people, recover from the infection. So anyone who says, "Oh, but we don't know if there are antibodies to the virus," that's nonsense. That's never been shown for anything, and except for antiretrovirals. So retroviruses are a different, more challenging category, so it's different. But typically, for all viral infections, you clear the infection on your own. So the second antibody test is useful for saying whether you have recovered and have the antibodies and are therefore immune. We don't know for how long you'll be immune. You could be immune for 6 months, you could be immune for a lifetime. Like if you get measles, you're immune essentially for a lifetime. There are some viruses which you're immune only for a short period of time, right? So the antibody test is important for telling us our individual immunity, but also for population immunity. So it's a way of saying, okay, these people can be safe to be let back onto planes, or if you want to go that route. I mean, I think for India, all this stuff is going to be a little irrelevant, because I think that what the lockdown has shown us is that we can't control things as much as other countries can. So we're going to scale out to herd immunity much faster than other countries. It means more short-term pain, but I think we will be the first large economy that also emerges from COVID, just because of this. Whereas, the US will continue to have outbreaks into 2021. They'll put a brake on it, then they'll remove the brake, the disease will grow again, then they'll put another brake on it. That's how they'll go in these jumps up and down. I don't think we have that luxury, and in some sense, we'll take all of our beating right at the beginning, perhaps, and that will be the end of it.
Sure. There's also a question about plasma therapy here, if you see that as effective and a good solution, at least for now.
So plasma therapy is a very, very old idea. It predates even vaccines to some extent. And plasma is simply the fact that you take the plasma. Plasma is just a component of blood, and which has the antibody. So you're taking it from one person and effectively injecting that into another person. Now, there are side effects from plasma therapy. The body might reject it. It tends to work quite well sometimes, but it's a totally non-scalable proposition, right? So you can't actually make millions of doses of plasma therapy. So it's a nice theoretical concept. It may even work. But how do I provide plasma therapy to hundreds of millions of people? I'm not sure. It's never been done.
Sure. Moving on to some questions from a public health perspective, there's one on the effects of the interventions on public health allocations and spending for the underprivileged sections. Mm-hmm. So, with large philanthropies like the Gates or the Azim Premji Foundation, what would your recommendations be? And even for the Ministry of Health and Family Welfare?
See, for me personally as well, I think as a society, there has never been a more important time we'll see in our lifetimes to really spend money on helping people out. I mean, literally, if we had anything that we plan to give over our lifetimes, this would be the weeks to do it. Because people are literally, suffering and dying out there. I think we should if it's feeding programs, if it's ways to, just help people survive through to the end of the year, just provide them enough money. That's really where we should just be spending a huge amount of money, all individually and collectively. I can't imagine anything worse than this happening to so many people at such a short period of time. And this is global, right? There are 60 million people who filed for unemployment in the US. In India, we don't see those numbers in a public way because we don't collect that kind of data. But we get so many anecdotal reports of such vast amounts of distress around the country. So I would just say, there are times when you spend money on things which are long-term, like changing policy or developing systems and so forth. But there are times when it is important to spend the money for short-term, which is feed the person now. And I think there are times for both of these, and this is one of those short-term things. Just help people out wherever they are right now, because it'll never make as big a difference to their lives as what you're doing today.
So if you had to give some pointed advice on, advocacy goals that the public health community should pursue, to build resilient health systems and to mitigate future outbreaks and the consequences, what would those be? Like just a few key things.
See, to me, it's almost so stupid, no? Because every day we lose about 50,000 crores according to Niti Aayog, maybe about 40,000 crores according to other estimates because of COVID. That is our total health budget per year. We could have spent this money over each year for the last 20 years. We could have dealt with every infectious and chronic disease that was out there. We would not even be in this situation right now. We are in this situation today because we didn't spend that money over 20 years. So there's no point saying, what will I do today for the future? I mean, come on, it's a no-brainer. We should have been spending this money for such a long period of time. And if you had to point a finger somewhere, it is that as a society, we did not prioritize health or health systems, and we are paying the price for it now. So I think the future is fine, do whatever you want for the future, certainly spend much more money on health. But it's frustrating that, this lockdown has cost so much money, and we could have had a much shorter lockdown. We could have had a 2-week lockdown and had the same effect if we'd had the bed capacity, the healthcare workers, all of that in place, and you can't build, I think Rajiv Sadanan, the former health secretary of Kerala, said very nicely, he said, you can't build a health system to deal with an emergency in the middle of that emergency. Either you did it or you didn't. And you're going to see a huge difference in the outcomes in the next 6 weeks between Tamil Nadu, Kerala, Karnataka, Andhra Pradesh, Telangana, and to some extent Maharashtra. And you're going to see a totally different world, in the UP, Bihar, Madhya Pradesh, Jharkhand, West Bengal, and to some extent Rajasthan. So that's going to be where that cost of not having spent is going to be so amply clear.
Right. Do you also see some significant public-private partnerships emerging while we deal with the emergency, which you think will be an enduring model?
Public-private partnerships, it is happening to some extent. To me, that word is always a little vague. It never really, I don't know what that actually means. Certainly the private sector is, let me put it in a slightly different way, not exactly the answer to your question, but you have to remember that in our country, most people seek care from the private sector. So one of the things I've been urging government to do is not lock down. See, when we see the surge coming in about 3-4 weeks from now, it will be important not to respond to that by locking down. Because when the government is not able to help them, you're sitting at home, you have someone who's dying, the last thing you want to do is the government to say you can't even have an auto or a taxi to take that person into some hospital that you know, right? So I would say the best thing that the government can do is let people at least get access to care where they can right now. Please do not lock down in the middle of the epidemic. Let at least people protect themselves in the middle of the epidemic in whichever way they can. If you can't help them, let someone else help. So I think the private role is going to be in that sort of a way. I think that's what we have to already anticipate and demand, to say, give us access to care. Because what will kill the most people in India is lack of access. If people don't seek care on time, if they say, auto nahi hai, I can't go find a place to go, that's what is going to kill people. So not exactly what you asked for, but it just reminded me that we've got to be ready for this, and we've got to be ready for us to protect ourselves. And I don't mean just us, I mean provide that agency to literally everyone in the country.
On the question of access to healthcare, one particularly underserved area, which is the large part of the country, is the rural areas. So how do we ensure that those populations are able to get proper access?
This is actually a really important question. And I think this is also what the government has been thinking of for a while at the central level, which is some places like Ranchi, you're never going to be able to build a 2,000-bed hospital overnight with the staff for it. Which is why I think the idea of having mobile ICUs on trains, and the plan is for say 1 or 2 lakh of these beds to be on these mobile on these trains, is actually a really good idea, because it's not going to be the same outbreak in every single place. It's not going to happen in UP at the same time as Maharashtra. Maharashtra may peak earlier, and the reason it peaks earlier is, like I told you before, the thing that determines where you are on the epidemic curve is when you got your first cases. And Maharashtra got it much before UP. So Maharashtra will peak about 2 weeks or 3 weeks before UP. But then you send the trains into the rural place in Maharashtra that need it. Then you send it to UP. We need a mobile capacity that's able to deal with that. And let's not forget that it's not about beds only. It's really about doctors and nurses and anesthesiologists and people who can run ventilators, and all these are highly specialized skills. I know we talk about ventilators as if it's something which you just turn on the switch and the person is okay. A ventilator is a highly specialized instrument. It's like anesthesia. If you give too much, the patient dies. If you give too little, also the patient dies out of pain. So these are very finely graded things which take a lot of experience, and the number of people we have in our country to run these things is not that many. So if we only have 50,000 ventilators in the country, then we only have 50,000, the capacity of people to run those 50,000 ventilators. You can buy 300,000 more ventilators, but where are the people who know how to run those ventilators exactly? So there's a lot that we didn't invest in. These are the things that we didn't put the money into for 20 years. And I don't blame one government or another government. I blame all governments, and eventually I blame ourselves. We didn't prioritize this as a people. So.
Sure. There's a follow-up question on the question of infrastructure. US and Europe have had the best in the world, and higher spending from both government and private sector for very, very long, at least compared to India. In spite of that, we've seen the situation to be much worse in some of the countries, and so many deaths. Why is that?
See, they have spent, but it is, again, keep in mind, I don't know what you're comparing that against. They have so many deaths because that was their population. The US has more deaths than Europe because they have the higher population. And every country will see this, whether it's Nigeria, or Indonesia, or Brazil, or India, or whoever else it is, Pakistan, Bangladesh. The only thing that differentiates us from any other country in terms of deaths is the timing, right? It's only all about timing. At a doubling rate of every 5 days, if I'm sitting on the first of the month and I have 1,000 cases, that's the same as having 64,000 cases at the end of the month. So I don't think there's any difference between any of these countries. You have to remember, the fundamental truth of this virus is very simple. It is a virus to which no human being has immunity. There's nothing special about Indians or Pakistanis or Sri Lankans or Bangladeshis relative to Europeans. So you're going to see all of this everywhere. This is only a matter of time. see, they've bent the curve in Italy for right now, but they're going to have to come back and deal with this in a couple of months from now.
Sure.
So,
another question we have is, well, while 70% of the Indian population seeks private healthcare, what, in your opinion, would be the approach towards balancing the pricing of services while maintaining equity of services from the healthcare provider perspective?
you mean during the epidemic?
The question is framed more generally, but I would assume that we're talking specifically right now as well.
I don't know what's going to happen during the epidemic, to be honest. I'm sure there are people who will price gouge. There are people who are going to do all sorts of nonsense. So I don't even want to comment on it. I think, I'm a firm believer that for a country like India, eventually it has to be publicly paid services for the entire country, not just for half, not just for a third, for the entire country. We should adopt that sort of a model, and that's what builds a system capacity in a consistent way. We've just never sort of gone for that sort of universal health coverage in a way, but we will get there. I know we'll get there after we've exhausted all the alternatives, but that is the only long-term option.
Do you also see some shift in the health insurance sector, again, as a byproduct?
See, health insurance is not health insurance is not a long-term solution. Health is health is different from saying just auto insurance or something else. There's a fundamental different structure to it. So health insurance is not going to be a long-term, you still have the question of provision of healthcare. You need quality, you need standards, you need someone who is not going to rip the system off, by figuring out how to get paid rather than providing care. I think health insurance does not necessarily promote that. What you need is like an NHS model where doctors are essentially on salary. They get paid their salary whether they say 5 patients, 50 patients, or 200 patients. It has to just be a job like that. If you look at the best health systems in our country, they tend to work like that. Take the railways health system, right? The railways health system is a very good system, and you can have complex surgeries, you can have transplants done, but you also get routine care. And I think people discount the fact that the public sector can do some things really well. It can run a good railway system, at least for starters. It can run a railway healthcare system. Is it so beyond our capacity to say that we cannot have a publicly paid system, but privately served like it is in the NHS? In the NHS, in the National Health Service in the UK, every doctor is a private contractor. Nothing wrong with that. But this is what we need to aim towards. I hope we will reset our priorities with respect to health after this and build something which is really something long-term, which deals with people both in the short term as well as in the long term. Because again, let me get to a certain number. Let's assume that there are 1 million deaths from COVID. Hopefully not, but let's say there are. In the grand scheme of things, 1 million deaths from COVID, given that we already have 7 to 8 million deaths a year from all causes, is not a large proportion, right? So if it was spread over a 2-year period, you won't even notice COVID from a death perspective. It's because it's bunched into 6 weeks that you notice it so much and it causes so much chaos. But if you really think about it, people don't die primarily of COVID. People die of everything else. Diabetes, not having dialysis. What about all of that? I don't mean in a time like COVID. I mean just in general, right? During a normal time, there are hundreds of thousands of people who are dying because of lack of access to stuff which should be very, very routine. And I think it's time to then reorient and say that what is routine is also good for the emergency and figure out how to get everyone, whether rich or poor, access to it. And I hope that this COVID crisis has that as the outcome, because if we use this crisis for the opportunity for building a national health system of that kind, we would have saved vastly more lives than we would have lost through COVID, vastly more. And I think that's what we should really focus on.
So we're at 12:30, Ramanan. As a concluding thought, we've talked policy and systems, but what should people and communities try and take care of and do, especially now that we're, in the staggered lifting of the lockdown?
So the next stage, which you will likely see coming out of government as well, is that we will be moving from a prevention testing strategy to a mitigation strategy. The mitigation is, how do you make sure that we get anyone above the age of 60 or 65 to be early identified, figure out their risk factors, and get them into a hospital as soon as possible should they have any sort of symptoms of COVID. And I think we should all be very focused on this. We should try to help, our communities, our neighbors. And the number one thing I would say, which your community of social sector leaders should lead on, is stigma. The levels of stigma about COVID are just ridiculous and stupid. This is the reason why healthcare workers are getting stoned, why there's a doctor who's denied a decent burial in Tamil Nadu. The stigma will cost us a lot, because if we have stigma, people will not come forward to get tested. If we have stigma, we will not have community cohesion when there's a death. People will just move away from there. And I think we've got to explain to people that 99% of people with COVID will be fine. And I think we need to flip that. Let's not focus on this 1%. I'm explaining the 1% to you guys as a population that understands statistics, but let's focus on the fact that most people with COVID will be just fine. And let's make sure that we can get stigma out of the way, because that's going to be our biggest challenge to any sort of community cohesion within workplaces, within neighborhoods, etc. Because if your neighbor has what looks like COVID and you think, I don't want to get the disease and I'm 40 years old and I don't want to die, then, that's not a good solution. You've got to go out and help that person. And I think this is what we've got to do. That I think young people below the age of 50, 10 to 50, you're at very, very, very low risk. Please go out and do what you can to help.
So on that note, we close the session. Thank you so much for your time, Ramanan. This was really, really insightful. Thank you for laying out the prior context. I think we've all been very, very curious about that.